when COVID was in sort of its most rampant stages, it was a ethical paradox. Do you have somebody go to the emergency department if they're suicidal when the emergency department might be overrun with COVID-19 cases? We were suddenly thrust into a whole new reality of realizing that we, for safety purposes, had to move to online modalities, and probably pushed us 10 to 20 years faster into that than we might have otherwise experienced. And with that came some interesting perceptions that we can no longer ask about suicide risk or screen for suicide risk, and that maybe during the time of COVID, we might suspend screening or assessments. And this sort of perception that we had to be in the same room with the patient kind of played into this idea that we couldn't do these things remotely. So clearly we can, and we have to, and a don't ask approach to saving lives is not going to be effective. What I would want to say about it is that I think too many providers work in a place of fear of malpractice. And so out of fear, they practice defensively, and that doesn't always mean that they're working in the client's best interest. And so what I really want to emphasize is that you can work in the gray areas of even high risk in a thoughtful way, and that fearing litigation should not be the tail that wags the dog of what you do. I really want to demystify this notion that, that we can't work with suicide risk or people in crisis in a remote way. Of course we can. It's just a matter of being thoughtful about it, thinking upstream, and being really clear about what we're going to do if this or that happens, and what the contingencies are for our response to work in your best interest. What you do should be based on what's in the patient's best interest. And so if you think about that in terms of informed consent, clear expectations, fighting for or advocating for a strong alliance. We know good alliances drive our best outcomes. Creating a framework or a set of steps of engagement, consultation, maybe an extended evaluation, and then maybe a course of treatment, and where they're doing a treatment that's actually been proven to be effective. So it's always good practice to have thorough, thoughtful, informed consent, to have family members be involved or be looped in. We do this routinely with children and adolescents, but even with adults, to be looped into the care. And so we want to optimize those ingredients that we know are the key to therapeutic success. And this is across psychiatry and counseling and psychotherapy, multidisciplinary, that when a patient has a head of steam and feels like this person can help me, and care that's being rendered is being rendered in a thoughtful way, always pursuing what's in the patient's best interest, and well documented with consultation, bringing family members in as appropriate, you're not only practicing really well, you're continuing to work in the patient's best interest. And if all those are reflected in the medical record and actually part of the practice, then you're looking at really high quality practice that works in the patient's best interest, that decreases liability exposure for the provider or the system of care. And the threat of liability plummets to almost nothing.